Hello, the following slides have been selected just to highlight the extremely most important aspects of the content covered until now. Nevertheless, they are not all inclusive. It means that you still are supposed to learn, study and learn everything that has been covered in the PowerPoints in class and everything that is included in your syllabus and lesson plan. It means that anything can be tested if it is included in your syllabus. The first week class include many topics that can be tested. For example, the concepts of pharmacokinetics and pharmacodynamics. To know that pharmacokinetics are all those processes that the body do on the medication to reach finally to the site of action, while pharmacodynamics include all the process that uses the medication to make a modification, a change, and an action in the body. The pharmacokinetics includes four main processes: the process of absorption, the process of distribution, the process of metabolism, and the process of excretion. The absorption is when the medication is placed in any part of the body. I mean, could be in the digestive tract, could be under the tongue, could be in the rectum, could be in the muscle, could be the subcutaneous. There is a process of absorption in which the medication that is outside the circulation, outside the blood, need to travel to be in the blood and then be distributed in all the body. The only via that has not absorption, of course, is the intravenous via, because the medication is placed directly in the circulation. The route of administration, of course, affects the absorption. The most common form of given medication is the enteral via. So it is most commonly the oral or PO via. In this case, medications that are solid need to be first dissolved, then are going to pass to the stomach, then from the stomach after a while is going to move to the intestine. The movement from the content of the stomach into the intestine is going to depend on what you eat. So if you eat something that is heavy, it will stay longer in the stomach and then is going to last longer to reach the intestine where the medications are absorbed. It means that the time of beginning of the action is going to be delayed. Also depends if the medication is solid or liquid. Liquid medications are absorbed faster because they are already dissolved, and depends on many other factors, because some medications are affected by the presence of food, and even the food can inactivate the medication. So we need to learn which medication need to be given with empty stomach and which medications are okay to be given with the food. The parenteral via includes a syringe and needle, so you need to bypass the absorption in the intestine, introducing directly the medication through a needle in the body. The parenteral include the subcutaneous, which is a very slow route, the intramuscular, and the intravenous. Remember that intravenous is the fastest of all the via because there is no absorption. There is a possibility of giving medication, certain type of medication topically. And one of the topical via is the transdermal. Transdermal medications are given on purpose very slowly, so to be absorbed very slowly through the skin. There are other vias, so you can have a medication administered in the spinal cord, in the cerebrospinal fluid, intrathecal. You can have medications administered through an endotracheal tube. That, by the way, is a very fast via of administration of medication. As said before, the rate of absorption determines how soon the medication will reach the site of action. And for example, medications that are liquid are going to be absorbed faster through the oral via than tablets. And the tablets, simple tablets, are going to be absorbed much more rapid than, for example, extended release tablets. You know that extended release tablets or enteric coated tablets are designed in the factories to be dissolving very slowly or dissolving only in certain parts of the GI tube in a way that the medication is released very slowly. Don't forget that those extended release tablets and those enteric coated tablets cannot be crushed because you are destroying this specialized process that makes the medication being delivered gradually along the day. As I said before, food, antacids, and the presence of other drugs can modify the rate of absorption. For that reason, there are many medications that cannot be given with food, need to be given with empty stomach. And you need to know that those medications preferably must be given 1 hour before meals, especially in the morning when you wake up and your stomach is empty, and also 1 hour before antacids, because antacids work like the meals, inhibit the absorption. As we saw, not all the medication that is administered reaches the site of action and brings the concept of bioavailability. The bioavailability is from the total, I mean from the 100% of the dose given, how much reach in reality to the site of action. So if you, for example, swallow 500 milligrams of acetaminophen, probably only few milligrams are going to reach the receptors of acetaminophen that are inhibiting the production of prostaglandins in the brain and decreasing the pain. This is the proportion of the drug that is reaching the site of action. One of the important factors that can affect bioavailability when the medication is administered orally, which is the most common route of administration, is the first pass effect. It has relation with the anatomy because anything that is absorbed in the intestine should go to only one vein called portal vein. The portal vein reaches the liver directly. So everything that is absorbed in the intestine must go directly to the liver. In the liver is where we have all those enzymes that destroy medication, the cytochrome P450, etc. Those enzymatic systems destroy most of the medication, and just a small amount survive and can then reach the systemic circulation and then reach the site of action. For that reason, usually the doses of the medications given orally are much higher, bigger than the doses of the same medication given intravenous, because intravenous, subcutaneous, I mean parenteral route, even the sublingual route bypass the first pass through the liver, and the medication reaches first the circulation, the systemic circulation, and the site of action, and then after reaching the site of action is when the medication is passing through the liver and destroyed. So the first pass that occurs in the PO oral enteral via is avoided, this first pass, when it is administered parenterally or sublingual. And for that reason, the medication reaches the site of action sooner, stronger, in higher concentration, and are more potent in this via. What we have here is a visual representation of how could be understood those enzymatic mechanisms or systems that we have in the liver that metabolize or biotransform the medication that you receive. Any medication, all the medications that you receive are going to be metabolized or biotransformed by those enzymatic systems in the liver. Exactly not all, but the big majority. So if it is given orally, this biotransformation is going to occur first. If it is given parenterally or um, through the sublingual route, this metabolism or biotransformation is going to be delayed after the medication reaches the systemic circulation and reaches the site of action. So this biotransformation occurs later. This system could be conceived or imagined as scissors that destroy the medication. And you need to know that the same scissor, the same system, the cytochrome P450, can be induced or potentiated or enhanced or made stronger by certain substances, or can be inhibited, can be diminished by other substances. Understand that if those scissors that destroy the medications are bigger, then the medication is going to be destroyed sooner, is going to be biotransformed sooner and more efficiently. So the medication will wear out sooner and and more intensely. If this system is inhibited, is decreased, is made weaker, then the medication will survive for longer, and then the medication has the capacity of being more potent than usual. It is important because if you are stabilized with a dose and now something enhance the destruction of the medication, this dose that was working before now is not working anymore. Why? Because it's destroyed. The medication is metabolized, is biotransformed sooner and more efficiently. So for example, if a woman is taking oral contraceptives to control her fertility, now when she starts taking certain medications that are hepatic inducers, like anticonvulsants medication that we studied or antibiotics that we need to study, then the contraceptives can be destroyed, metabolized by transformed sooner and more efficiently, and then could lose its effect, and now the woman can become pregnant. Women that need to consume those medications for health needs need to use a barrier method, a non-hormonal pill, because the barrier method cannot be affected by this phenomenon. Meanwhile, is taking those medications at less. By the contrary, when a person that has a dose of medication well established consume any substance like grapefruit juice, which is very important, or cimetidine, or many others that potentiate enhance the mechanism of destruction of the medication, now, inhibit or decrease the mechanism of destruction of the medication, like in this case, make the seizure smaller. Now the medication is not destroyed. Now the medication survives. Now the medication persists for longer and in higher concentration. When we have a medication that is in the body in higher concentration than needed, lasting longer than expected, then this medication becoming too potent, is this medication becoming toxic. So adverse effects can occur. And this is what happens, for example, with the calcium channel blockers like amlodipine, nifedipine, verapamil, and diltiazem, that are medications that decrease blood pressure through vasodilation and slow down the heart rate. So now when a person is taking, for example, diltiazem, a calcium channel blocker with grapefruit juice, this medication becomes stronger, and then the blood pressure will decrease too much. When the blood pressure decreases too much, it's no good, obviously. The heart rate is going to decrease too much. When the heart rate decreases too much, it's no good. obviously it is not the desired effect. Same happens with the statins, medication to decrease the cholesterol in the body that you already know. So when a person is taking a statin and the adequate dose will take this medication with cimetidine or grapefruit juice, now the statins becomes stronger, becomes higher concentration and can become toxic. All we know that the statin toxicity includes the liver. Hepatotoxicity can damage the liver, but the most serious, the most catastrophic, the most lethal of the side effect of the statins is the myopathy, the breakdown of the muscle, the rhabdomyolysis that can be lethal. This is the reason for which some medication should not be taken with grapefruit, because the grapefruit can make this medication more potent, so potent that can become toxic. So what we see is happening mainly in the liver is the process of metabolism or biotransformation. That is no more than changes that are made in the chemical structure of the medication consumed, done mainly by a system of enzymes that are in the liver that could mainly decrease the activity of the drug, but in some cases can increase the activity of the drug. Uh, Now you understand that if a person has a problem in the liver, have a disease that affects the capacity of the liver to metabolize the medication, like for example, people that are old, they have also old livers, or people that have liver disease. The most serious liver disease is called cirrhosis, that deteriorates the liver a lot. Then these people can have a decreased metabolism, so the medication will last longer and in higher concentration. So the risk of toxicity in old people and people having liver disease is higher. So remember that when we give a medication, a dose of medication, the concentration in the blood increases because we consume the medication. But immediately this concentration will decrease. Why? Because the liver breaks down or modify the medication. That's why the concentration tends to drop. Part of this medication then is excreted by the kidneys. That has not been mentioned yet. But then a second dose of the medication is given, so the concentration in blood increases again. And again, the liver will metabolize the medication and the kidneys will excrete the medication, and another dose of the medication is given. And in this process, we have this up and down of the concentration of the medications in the blood. That is what happens. And depending of how long it takes for the body, for the liver and the kidneys, the destruction or elimination of the medication, that by the way is called half-life. The time required to destroy, to reduce the concentration of the medication to a half, I mean in 50%, is called half-life, and is different for each medication. For some medication is shorter, for some medication is longer. This half-life, with no more the time that takes the liver and the kidneys to decrease the concentration of the medication, this descent that you see here to 50% to half, is what is called half-life. This will determine the interval that need to medication be given. Are some medication with a very short half-life and need to be given frequently, every 4 hours, every 6 hours. There are medications with a very long half-life and are given every day, every 24 hours. So it's easy to understand. Also, it's important not going too high, neither too high nor too low. If you go too high and you surpass the maximum therapeutic concentration, active concentration, good concentration, then you enter in the range of toxicity. Too much of something can be alcohol, can be water, can be anything. too much of something is not good. And when there is too much of something, it is called toxicity. So if we give too much dose, too frequent, and the concentration is above the upper limit, then we enter in the range of toxicity. By the contrary, if we give it too little or too distant, then the concentration drops below the therapeutic level, the acting level. The enters the subtherapeutic range and it's not working. And if you are taking a medication, it's supposed to work. Okay, so it is something that the pharmacists, the scientists, the doctors, and the nurse need to know that based on the characteristic of this medication, there is a dose that is adequate for the size of the person and the condition of the person, and there is an interval of dosing that is pertinent for the same characteristic that need to be respected and known, because we cannot know everything. Yeah, we cannot know everything. That's why you have a drug guide that you need to get used to consult. The limits, the upper and lower limits, the limit that prevents you going to toxicity and the lower limit that prevents you going to a subtherapeutic range is what is called therapeutic index, is this range. Some medication have a very wide therapeutic index, so the upper limit is very far distant from the lower limit. Those are safe medication because it's very difficult to surpass the limits because are very high or very low. This is a wide and safe and comfortable therapeutic index. You'll see that over-the-counter medications like acetaminophen and antacids are sold without prescription. Why? Because they have a wide therapeutic index. But there are some medication with a very narrow therapeutic index. So the upper limit is very near the lower limit. Those medications are very delicate. Of course, are never over the counter, need to be prescribed. And the most important, doctors and nurses need to be monitoring the blood level. So blood is going to be drawn with a syringe from time to time to check exactly in which concentration is the medication, and are those medications like dioxin, lithium, anticonvulsants that we already have been mentioning the therapeutic level. Yes, those are medication with a narrow therapeutic level and high potential of toxicity. In this picture, we can see how the concentration of the medication oscillate as the metabolism and the excretion decreases the concentration of the medication in the blood, and how the next dose increases the concentration. This is something to have in mind when the doctors orders levels of the medication in blood, because doctors could be interested in the maximum concentration, that is called the peak of concentration, and the lowest concentration, that is called the trough concentration. We need to know that to detect or to measure the lowest concentration, we need to draw the blood. We need to draw the blood and send the blood to the lab immediately before the next dose, because after the next dose is given, the concentration increases. So the trough, the lowest concentration, requires drawing the blood immediately before or soon before the next dose. By the contrary, for the peak, the blood is going to be drawn after the medication is given, not immediately after the medication is given. You need to leave a certain time, because as you notice, the ascent of the concentration is gradual, and you need to wait like 30 minutes, 60 minutes after the dose has been given to draw the blood. This is the famous peak and trough of the drug concentrations. In this slide, you can see bigger what I explained before in relation to the therapeutic index. okay, the range between the maximum and lower dose, that is like the peak and the trough, and to understand that some medication have a wide therapeutic index, and those are very safe medication, while in contrast with medication that have a very narrow therapeutic index that are more potential of being toxic and requires more care at the moment of determining the concentration of the medication in the blood. This slide is to enhance the concept of half-life, which is the time in which the maximum concentration of the medication after being administered drops in 50%. So half the concentration, when the time that takes for half the concentration to drop, okay, is what is called half-life. And this determines the interval of administration of the medication. When the drug reaches the site of action, that usually is a receptor, is when the pharmacodynamics starts, and is where the concept of agonist and antagonist is important. An agonist is a medication, a chemical substance that when interacting with the receptor stimulates the receptor, generally producing a reaction similar to the reaction that originally produces the natural substance that uses this receptor. This is the case of the morphine that acts in the receptor that normally receive the endorphins that are produced by the organism, stimulating those receptors. By the contrary, antagonist is a chemical substance that when interacting with the receptor is going to block the activity that produces the receptor. It is the case of the naloxone. Naloxone is an antagonist of the morphine of the opioid, that when a person has too much stimulation of the receptors of the morphine, the naloxone blocks those receptors, inhibiting the action of the morphine. When a nurse assumes the responsibility of carrying out the administration of a medication prescribed by the prescriber, it's important to be careful of not committing mistakes. And this is the concept of the rights. Rights prevent mistake. The right patient, the right drug, the right dose, the right timing, the right route, documenting what you did, evaluating the response to the medication, educating the client about the medication, and understanding the legal implications of the right of the client to refuse a medication. You know well, you must know well, okay, the different situations in which those rights apply. You are supposed to know and understand that the right dose is one of the important, all the rights are important, but one of the rights that are more important. And this is taken over in detail when you go over the class of drug calculations and the program that the ATI system gives you to practice in depth the different ways of doing drug calculation properly. That is something that is learned only practicing, practicing, practicing. Don't expect that an angel is going to touch you and as a miracle you learn that. The only way of learning that is studying and practicing, practicing, practicing. Please go over the ATI program that teaches you how to do correctly drug calculation. Choose your preferred method and master drug calculation. Among the different situations in which drug calculation is so important, don't forget that in pediatrics, that deal with children, is especially important because they are small and they have immature liver and kidney function that make them very susceptible for toxicity or subtherapeutic action of the medication. Understand that not all children comes in the same size and age. For that reason, necessarily you need to understand what is a dose by weight, how the books the drug guides and the doctor give you a dose per kilo. So you need to find how many kilos have the child to know the individualized dose of this client. Yes, the pediatric dose are based in the body weight in kilos or the body surface area. That is something that you learn later how to calculate, body surface area. All clients are important, but they are again in a special situation in the case of pregnancy and breastfeeding, because it refers again to the child, to the fetus or to the child. So you need to know that the creation of a life, you are alive, you were created by the nature and by your parents. Okay, you are alive, and for the creation of yourself, of your life, okay, when you were an embryo and you were already there, you had all the genetics, okay, references or patterns or information to make what you are in this moment. In this moment, you were very susceptible to the action of medication that can affect this creation of yourself or the life are called teratogens. In the teratogenic medications can be very risky, especially in the first trimester of the pregnancy. For that reason, the medications are classified depending on the safety in pregnancy from A to D, being the A the most safe, the safest, and D something that need to be taken in consideration. It is worthy the risk in contrast with the need of the medication. But there are some medications that are totally prohibited in pregnancy that destroy the life that was forming there, and those medications are classified as X. You are also responsible to understand what is addiction, what was covered is in the PowerPoint, and to understand that the medication that have the potential of producing addiction are controlled substances by the DEA, and they classify the medication depending in the potential of addiction, being one, the maximum potential. Those medications have no medical use, are drug of abuse, and the medications that have, yes, medical use prescription are classified from 2 to 4 to 5, being 2 the most addictive, 5 the least addictive of the addictive medication. Even when the medications are given to the right client, the right doses, in the right moment, they can produce toxicity. And it is very variable because individuals are very variable. You need to know which one of the toxicity. You need to know that hepatotoxicity refers to the liver. You need to know the symptoms, the experience of usually patient with liver toxicity, and the tests that are, tested or checked for liver toxicity. Nephrotoxicity refers to the kidneys. You need to know the same, the tests that are for renal function. Ototoxicity have no specific test immediately, but the symptoms like tinnitus, loss of hearing, and vertigo are the ones that warn the nurse that the patient could be experiencing ototoxicity. The allergic reactions can be mild or can be very severe. The severe allergic reactions can produce anaphylaxis and angioedema and can be life-threatening. And you need to know that epinephrine is what you need to be used to save the life of those patients presenting this allergic reaction. A person that is presenting this swelling or is presenting problems to speak or to a sound when they breathe in and out called a stridor are patients that are at risk of immediate death. We study, when we study, for example, ACE inhibitors, that this angioedema that some patients develop with ACE inhibitors can kill the patient. So a poor patient that have just high blood pressure, it takes a dose of this medication, and then if the nurse is not aware that the medication can produce angioedema, not in the majority, just in a few of the patients taking ACE inhibitors, but if you are not aware that the patient presents the symptoms, the patient can die if we don't intervene properly. Extrapyramidal syndrome, some manifestation that occurs when patients receive antipsychotic medication. And it is because the antipsychotic medication decreases the amount of dopamine in the brain. And then the person can present something like the Parkinson's disease, can present torticollis, open mouth, deviation of the eye, acute dystonia, restlessness and continuous movement, the akathisia, and even lips movement, abdominal movement that are the beginning of the tardive dyskinesia. It's very important that you know that sometimes those symptoms can be managed just reducing the dose of the medication and use the antidote of the toxicity, which is the benztropine. So medication can produce depression of the bone marrow where the red blood cells, white blood cells, and platelets are produced. And that's why we need to check the CBC periodically in those patients, okay? One of the two medications that we have studied that produce this is the carbamazepine for seizures and the clozapine as an antipsychotic. When administering oral medication, one of the most important principles that you need to have is that you need to evaluate the client's capacity to swallow. You don't want to choke a person with a tablet, suffocate a person to death with a tablet because you don't understand or you are not, making the effort of evaluating the capacity to swallow the patient. It is the most important aspect, of course. The oral medications require the medication to be given clean, without bacteria and stuff coming from other clients. For that reason, you need to know what is the standard precaution that you learned in fundamentals. Administration of these oral medications are clean procedures, are not sterile procedures. Don't forget that to swallow something, you don't eat on bed because you can choke, especially if you are a client, you are weak, you are sick, so you need to sit the client. And remember that some patient, because difficulty to swallow, could have medication that could be liquid or medication that could be crushed and mixed with a little amount of applesauce or pudding to facilitate the swallowing. Nevertheless, don't forget that enteric-coated tablets and sustained-release capsules or tablets must not be crushed because then you destroy this expensive and complicated process that the factory developed to make the medication being released slowly or in certain parts of the GI. If you have a patient that have been prescribed this type of medication and the patient cannot swallow this medication, you need to discuss this with whom? With the client? No. With the supervisor? No. With other nurses? No. With the pharmacist? No. You need to discuss that with the person who prescribed this medication to this client. You need to inform the prescriber that the patient has a difficulty. And then once the prescriber understands that this kind of medication cannot be prescribed to the client because cannot be swallowed, then they'll find a way of bypassing this problem. It's important that liquid medication need to be measured very carefully. That's why you need to use a measurement cup, a graduated cup, and you need to consider what is the meniscus. If you don't know what is a meniscus, Google that, go to the dictionary, go to a book, go to the book of fundamentals and find that, or go in the PowerPoint to the pictures that are there. So you need to find that. You need to do your initiative to learn, okay? And we learn by ourselves. We don't learn because we go to the school. We learn from the book. We learn from the clients, and we learn from our interest in learning. So sorry if you don't agree, but this is the only way that we learn. So have initiative of find, okay, what you don't understand to find what it is. And remember that one of the mistakes that occurs when we have a liquid is the error of the parallelism. If you are not parallel, your eyes are not parallel to the bottom of the meniscus, then you misread the dose of the medication. You don't want a child that is a child that you love to be given the wrong dose. No, you don't like it. Okay, don't do that to other children. You as a nurse need to be very careful in this aspect. Okay, when the dose of the liquid medication is less than 5 milliliters, this cannot be measured with a cup, with a graduated cup. With a score cup, need to be used an oral syringe to measure that. And don't forget, if a patient vomits the medication because the body is rejecting the medication, don't repeat the dose and consult with the doctor. Clients that receive medication or food through a nasogastric tube or through a PEG tube, and you have the difference explained in your book and your PowerPoint, difference between nasogastric tube and percutaneous gastrostomy tube or PEG tube, PEG tube. It's very important that you know that they must take the medication this way because they cannot swallow. They have problem of dysphagia. And people that have problem of dysphagia are people that are predisposed to aspiration in the trachea and the bronchi and can die because of the aspiration, or can be very sick because of the aspiration. For that reason, at the moment of administering this kind of medication, the head of the bed needs to be elevated, because if you give this kind of medication in flat and recumbent position, the medication can ascend through the esophagus and can produce aspiration. That's why you need to elevate the head of the bed to these degrees, okay, in semi-Fowler or high Fowler, to prevent the aspiration. The stomach usually have certain amount of content, liquid content, that is left there from the previous administration of medication or food. And also with the gastric juices, you need to check how much of this liquid is there in the stomach, and it is something that you learn in fundamental, which is the checking of the residual. You need to aspirate this liquid, measure how much, and return the liquid to the client. Remember that some medications that are given solid must be crushed to be administered through the tube, but it doesn't include medications that are extended release or enteric coated that cannot be crushed. You need to clarify if this is the situation with your provider. The medication is administered with a syringe, big syringe as you see here, but you don't push the medication with the plunger. You allow the food, the water, or the medication to descend by gravity. You elevate the tube and the syringe so it descends by gravity. You should not mix different medications together in the syringe. You need to give them one by one, because medication can interact among them. And between each dose of the medication, a little amount of water is administered. And at the end, when you finish giving the medication or the food, you need to flush the tube with water, around 1 ounce of the liquid, so the tube is left clean with only water, to prevent clogging of the tube and fermentation of the content there and growth of bacteria. After feeding a client, after giving liquid or medication to a client, you need to leave the head elevated for a while, 45 degrees in a comfortable position. It's called semi-Fowler position, so the patient doesn't have regurgitation of the gastric content after receiving the medication. For medication via rectal suppositories or enemas, the patient needs to be in Sims position. Sims position is lateral, but always left lateral. It means the left side of the body is down against the mattress, and the upper leg, which is the right leg, should be flexed. This is the Sims position. Suppository need to be lubricated, to be inserted, and need to be inserted deep enough with a glove finger, so it's not expelled by the peristalsis. For vaginal suppositories, the position of the lady is the lithotomy position. That is the one that you see here. The same need to be lubricated and inserted deep to avoid being ejected. After administering suppositories, the patient should be rest in recumbent position, lying down position for a while, 10-15 minutes, so the suppository that is solid melts with the warmth of the body, and then the medication is spread in the mucosa and absorbed. If the person stands up quickly, then the medication could be expelled. For the parenteral administration of medication that we use a needle, you need to know the angle that should be used depending of the route. For intramuscular, it's always 90 degrees perpendicular to the skin. For subcutaneous, can be 45, the most common, or 90. It depends of the amount of adipose panicule or thickness that the patient has, but usually it's 45 degrees. For intradermal, which is the other one that we need to know, we go almost parallel to the skin. So we go with an angle from 10 to 15 degrees. You must know your needles. Your needle has two parameters to know. One is the length of the needle that is measured in inches, and one is the diameter of the needle, the internal diameter of the needle. The diameter of the needle is called gauge and is abbreviated with the letter G. The diameter of the needle is inverse to the number that identify this diameter. So the higher the number, the thinner the needle. The length is, as I said, measured in inches. If we are going to administer a shot to a bald person and the shot must reach the muscle, you need to understand that the needle needs to be long. So it needs to be at least 1.5 inch, sometimes 2 inches, depending of the constitution of the person. But if we are given the same intramuscular shot to a child, then with 1 inch is enough, because children have thinner muscle, skin, subcutaneous, and muscle. For subcutaneous and intradermal, we use very short needles. So usually we use 1/2 inch, or 3/4 of an inch, or 5/8 of an inch. So this is the range, okay? One of the most common use is the 5/8 of an inch. And of course, for subcutaneous and intradermal, we use very thin needles. So in the range of 25 to 27, this range is the usual range for intradermal and subcutaneous. For the intramuscular, we go around the 20 to 22 range. Okay, this is the range. Okay, so I always remember 21 because it's in the middle. Because usually the liquids that are administered intramuscular are a little thinner than the liquids administered subcutaneous or intradermal, and because you have a structurally stronger needle to penetrate many layers and reach the muscle. Those thick needles, like 18, 19, are used mainly for intravenous catheters. Medication for parenteral administration can come in ampoules or in vials. Vials frequently are multi-dose. The ampoules are unidose, only one dose. The ampoule comes in a glass container that has a neck that can be broken by a force. To break the neck, first we need to move any liquid that is in the head of the ampoule down, and then tapping in the head, and then with the protection of a gas, something clean, we are going to break, moving away of you the neck, and then the rim, that is the hole that is left there, should be not considered sterile. It's not sterile. Inside is sterile, but outside is not sterile. So when you introduce the needle, avoid touching the brim that you have here. And you need to use a filter needle to withdraw the liquid, because there is a possibility of having fragment shards of the glass in the liquid. You don't need to add air, because the air is entering as you draw the liquid. The air is entering through the hole, through the cavity that is there, and then this filter needle is going to be discarded, and a actual real sharp needle is going to be placed to administer the medication. Remember that if you are administering subcutaneous or intramuscular, you don't need to expel the bubble of air that could be in the syringe, because when you expel this bubble, then you contaminate, you make the needle wet with the liquid, which can produce irritation in the skin when penetrating the skin, or even staining on the skin. So you can leave the bubble. This bubble is going to have other functions, like plugging the track of the needle, preventing the medication from returning from the pocket in the muscle back into the skin. In the case of the vials, you need to clean the cap that is a rubber. So this is a cap that is removed, and then you have a rubber cap. This rubber cap needs to be cleaned with alcohol, and then you need to add, with a sharp needle, you need to add a amount of air that is the same amount of air. The same amount of liquid that you are going to withdraw is the amount of air that you are going to add. Once you add the air, then you invert the vial, so the liquid enters in contact with the needle, and then you withdraw the amount of liquid that you want to withdraw. For subcutaneous shots, as I mentioned, you use short needles in this range, 3/8 to 5/8 of inch, and you use fine needles in this range, 25, 27. Usually no more than 1 milliliter of solution is administered subcutaneous. You can leave the bubble of air. There is no need of expelling the bubble of air. Before penetrating the skin in an angle, usually 45, sometimes when the patient is very obese, 90 degrees, you need to make a pinch in the skin. This pinch is kept while you introduce the needle, while you introduce the liquid, and is kept until you remove the needle. After you remove the needle is when you release the pinch. There is no need of aspirating for blood in the subcutaneous shot, and there is no need of massaging the skin after the shot. So you can make a mild, just a mild pressure, especially when it is administered heparin, to minimize the formation of bruises, but you don't need to massage. Oil with a site of injection, especially when it is repeated, like insulin or heparin, should be rotated, because injecting in the same place is going to produce alteration in the subcutaneous that impair later the absorption of the medication. The rotation of the site usually is done in the same anatomic area. The most common site for subcutaneous injection is the abdomen, but also can be administered in the lateral part of the thigh or in the lateral and posterior part of the arms. For intramuscular medications, as I said before, we use the longer needles, 1 inch in children, 1.5 or 2 inches in adults, and we enter in a 90 degrees angle. It's important that not all muscles can be used for intramuscular, and depends on the age of the client. In children, usually less than 2 years of age, we use the muscle that is in the lateral part of the thigh, because it's the only muscle big enough as to receive intramuscular shots in small children. This muscle is called vastus lateralis, and is accepting no more than 1 milliliter of fluid. If for any reason the doctor orders more than 1 milliliter, need to be given in different shots. After age 2, the ventral gluteal in the buttocks is the preferred area, and this area in adults can accept until 3 milliliters. The deltoid muscle can be also used. You need to look in your book how to localize those muscles, because it's not enough to know where is it administered. You need to know the practical situation how to localize those muscles. That's why you have books that teach you that. And the deltoid side, that is 2 fingers, 2 centimeters below the acromion process, you can inject, but no more than 1 milliliter of fluid. Airlock is a technique that leaves the bubble of air in the liquid when administered intramuscular, and will prevent the liquid in the pockets administered in the muscle returning back to the skin. The Z-track technique needs to be known by you and is used when the medication to be injected could stain the skin, like for example iron, or could produce irritation in the skin. The Z-track technique includes using a clean needle that is not stained with the liquid and keeping a bubble of air, 0.2 to 0.3 milliliters of air. Then, after cleaning the skin and before penetrating the skin with the needle, you pull the skin in one direction and keep the skin pulled. Penetrate in 90 degrees, inject the substance, remove the needle, and then after you remove the needle, you release the skin, and the skin returning to the original position will make a Z-shaped track that prevents the liquid in the pocket returning to the skin, producing staining or irritation. Intravenous route is very delicate because the medication is deposited directly in the circulation. It's a very rapid beginning of action, it's a very potent beginning of action by passing the first pass, and is used for the administration of fluid, blood, and medications. That's why registered nurses are usually the ones that administer IV medications, and sometimes two registered nurses need to double check and document the administration of IV medication because the delicate form of administering. The way of administering IV medication is through vascular accesses. Those vascular accesses can be peripheral venous accesses that are generally localized in the forearm of the client, rarely in the hand, and central catheter, central venous access devices that are placed by the physician in the superior vena cava. One common method of administering IV medications by gravity is using the piggybacking system. In this system, we have two bags of medication. One bag is higher, the other one is lower. Notice the extension that allows to have one of the two bags lower. By physics, you know that the bag, the liquid that is going to pass first, is the bag that is higher, and this is called the secondary bag, the secondary medication, the one that is higher and is going to pass first. When the content of this secondary bag runs out and there is no more pressure of liquid, automatically the primary bag, is going to pass its liquid. It is very useful because when you have a medication, for example, an antibiotic that is going to pass in 30 minutes, only half an hour, you hang the antibiotic higher and the normal saline, the one that continues passing after the antibiotics the rest of the day, lower. So when the antibiotic passes in 30 minutes, in half an hour, automatically will start dripping the primary bag, and then you don't need to be pending, if the antibiotics already passed, because you know that automatically the primary bag, the one that is lower, will start passing the medication. For the administration of ophthalmic medication, you need to know that the medication is placed in a pocket created pulling down the lower lid, both drops and ointments. And it's important to clean of secretion first the eyes and make the client adopt a upright but leaning back head and looking upward to deviate the cornea, the sensible part of the eye, from the place where the drop or the ointment is going to be placed. And then you make a pocket here and pulling down the lower eyelid and allow the drops to fall in the pocket. When the drug is in the pocket, either ointment or drop, you ask the client to close the eyelids gently, no squeezing, and move the eyeball to distribute the medication in the eyeball. Meanwhile, the patient is doing that, you are going to press on the nasal bone here. You are going to press on the inner canthus, the inner part of the eye over the nasal bone for 1 minute to prevent the liquid going to the nose, because in the nose those medications are going to be absorbed quickly into the systemic circulation, producing systemic effects that you don't want to happen. For the eardrops administration, you need to know that the external canal has different shape depending on the age of the person. For that reason, in children that are 3 or younger, you need to pull down and back the earlobe to administer the eardrop and make the drop go deep in the external canal. Notice that the affected eye need to be up in a patient that is horizontal, and the head is horizontal, and must keep these positions some minutes after administered, leaving time for the medication to be distributed. In children 4 or older, then it's different. You pull up and back. Always is back, but then in children down, in older up. As I said before, nurses need to know how to do basic calculation to administer the adequate amount of medication, and this is critical and is demanded, is the law, is required that nurses learn to do calculation. We usually learn calculation in elementary school and high school, but then we reinforce that in the prerequisites, and now you have resources, okay, to practice that. And for medication calculation, you have your program of ATI with an excellent, okay, review, an excellent practice program that you can do many times. But as a practical approach, I still recommend, okay, keeping in your long-term memory formulas that will facilitate some, not all, of the most common calculations that you are going to be facing. A frequent situation is that doctors orders a dose, but you don't have exactly this dose that the doctor is ordering in the presentation that you have at hand. That's why you differentiate the dose prescribed, the dose that is prescribed by the prescriber or the doctor, and what you have the available. Yes. So if the doctor prescribed, okay, 500 milligrams, 500, and what you have is a tablet of 250, you know that 2 times 250 is 500, no? So if you put here 500 and you put here 250, and you with a calculator you make this division, you have 2. What means that you need to give 2 tablets, okay, of 250 to make the dose prescribed, which is 500. You can, apply this for more complex numbers, but it's the same principle. And this is times 1 because we are talking about tablets or capsules. But when the medication is liquid, you need to find the concentration of the medication. So for example, Tylenol comes in 250 milligrams per each 5 milliliters, not 1 milliliter, 5 milliliters. And where you find that? In the labels of the medication. So if the doctor's orders, okay, the doctor's order 500 milligrams of Tylenol liquid to a child, and what you have is Tylenol 250 in 5 milliliter, you divide 500 divided by 250, the calculator, yes, you have 2. And 2 multiplying 5, 2 times 5 is 10. So you give 10 milliliters. You can apply the same formula for more complex numbers. In the case that you need to administer IV fluids, then you can give the fluids either with a pump or without pump, in counting the number of drops per minute that is dripping there in the dripping chamber. If you are using a pump, the formula is the volume of liquid to administer in milliliters divided by the time in which the medication or the liquid need to be administered in hours, and that's it. This is what you do. Uh, if it is not using a pump, the formula is a little more complex. So it's the volume in milliliter divided by the time, but in minutes. So if they give you the time in hours, you need to convert that in minutes. If they give in minutes, you live in minutes. But if they give in hours, need to be converted in minutes. But need to be multiplied by the drop factor that is given to you or is found in the box where the tubing that you are going to be using is taken. We already have for our midterm a group of families of medication that we need to learn. To be a nurse, you need to know those medications. There is no bypass. There is no alternative. The best way of doing that is repetition, repetition, repetition. Many hours of study. All the nurses that already mastered their work have been doing the same. Many hours of study, repetition, repetition, repetition. An excellent way of studying is making notes, making flashcards with each group of medication and reading them several times and practicing many questions. There is no alternative. There is not an angel that can come and touch your head and make you knowledgeable like a miracle. It doesn't exist. All the person that, as me, have decided to become a nurse has been dedicated many hours daily of study, daily, no weekends, daily of study to learn the medication. Is the only alternative. There is no bypass. Have that in mind before the career is to advance and you notice that it is not what you want. But I'm pretty sure that you are going to do the correct and you are going to dedicate many daily hours of study because it's needed to become a nurse. But the first group of medication that I want to enforce, notice that those are not inclusive and just making a simplification, no for test purposes, it's for creating, the basement, creating the foundation to build, the more complex knowledge about this group of medication. The first group of medications are the medications that depress the nervous system that you know is a chapter in your ATI. The first group that I want to comment is a group that is frequently used, are called the benzodiazepines. Those medications have in common the termination PAM, with the exception of the chlordiazepam that is an exception of the rule. Those medications are used to calm down the nervous system, not too much, because too much is coma, too much is death, but for less in adequate doses calm down the anxiety, insomnia, but are also used for critically important medical conditions like the alcohol withdrawal, which is something that happens to alcoholics clients when they stop suddenly consuming alcohol. They can have seizures and they can die. So alcohol withdrawal is treated with benzodiazepines. And also something very important that I explained to you, which is called status epilepticus, when a person that suffers seizures has the seizures one after the other without recovering consciousness, without recovering, or the seizure lasts too long. In those cases, to stop the seizure, the person will receive IV diazepam or IV lorazepam to stop the seizure. So it's the drug of choice for status epilepticus. You know that for epilepsy, we use medication to prevent the seizure from happening. We have the barbiturate, we have the phenytoin, we have the carbamazepine, we have the valproic acid, etc., etc. But for stopping a seizure that is lasting too much, we use a PRN as needed emergency treatment, which is the IV benzodiazepine. As a depressor of the nervous system, the most important is that this medication can make your brain slow to respond. So if you have your brain slow to respond, then obviously it's not good to have a benzodiazepine before a test. Makes sense, no? And it's not good to have a benzodiazepine when you want to be smart and alert, no? It's not good to have a benzodiazepine if you're going to drive or manipulate a complex or risky machinery. No? It's not good to have a benzodiazepine if you plan to do exercise, ambulate, etc., because you can fall, you becomes incoordinated. It is called ataxia. When you lose because you are drunk or you are too sedated, etc., it is called ataxia. And this ataxia is a risk for falling. Falling in old people is very risky because the bones are very brittle. And of course, driving, having incoordination or ataxia, place you at risk of an accident. So it's something similar to the alcohol. When too much of this medication, benzodiazepines, is taken, then even the patient can develop coma and the respiratory center, the respiration could stop or could be insufficient. These severe depressions can be potentiated with alcohol and can be seen in patients that try to commit suicide with benzodiazepines. You need to know that in those cases when the respiration is impaired and the patient is severely intoxicated, an antidote called flumazenil is used to block the receptor of benzodiazepine and revert the respiratory depression. Another problem of the benzodiazepines are controlled substance because it has the potential of producing addiction. And a person that takes regularly benzodiazepine should discontinue the benzo gradually, tapering, because if there is an abrupt discontinuation, the person can have seizures as a consequence. Another family of medication of the mental health area that are super important are the antidepressants, because many people are taking antidepressants. We have several families of antidepressants, but the three more important are the tricyclic antidepressants, the monoamine oxidase inhibitors, and the selective serotonin reuptase inhibitors, the most commonly used. The tricyclic antidepressants, the prototype is the amitriptyline. There are others, okay, nortriptyline, imipramine, etc., but amitriptyline is the most commonly used. Of this group of medication for depression, we need to know two important side effects. They are potent anticholinergic. Anticholinergics are medications that oppose the action of the acetylcholine, oppose the parasympathetic nervous system, and it is going to inhibit this system. The consequences include dilation of the pupil, dry mouth, constipation, urinary retention, inhibit sweating. But in the case of the anticholinergic, we need to have very, very aware that patients with glaucoma, a disease that increases the intraocular pressure, and patients that have benign prostatic hypertrophy or BPH, a benign condition that enlarges the size of the prostate gland in all men and could produce urinary retention, should not be used this anticholinergic because the glaucoma can become very severe and the vision can be lost, or the patient could develop an acute urinary retention requiring catheterization. The other aspect of the antidepressant, the family of the tricyclic antidepressants, is that they are sedative, and for that reason should be given mainly at night, not during the day. The monoamine oxidase inhibitors have many, phenelcyclin, tranylcypromine, isocarboxyl, selegiline, but the prototype, let's leave it the phenelcyclin. Those medications have as side effect the potential of producing a very severe and potentially lethal elevation of the blood pressure. This elevation of the blood pressure occurs when the client taking MAO inhibitor consumes other type of medication like an SSRI or opioids, or simply medication that are over the counter for common cold or for nasal congestion, but also food rich in thiamine. We need to become knowledgeable of the food that is rich in thiamine. Is generally food that has been going through a process of fermentation, like beer, like wine, like cold cuts, okay, aged cheeses, etc. So you need to teach the client to avoid this kind of over-the-counters and food rich in thiamine to prevent an undesired hypertensive crisis. Of the SSRIs, the prototype, the fluoxetine, sertraline, paroxetine, the citalopram are the most commonly prescribed. You need to know all of them because anyone can be prescribed. You need to know that those medications are the most commonly used, that those medications are stimulants, so usually are given in the morning. And you need that, as in any antidepressant, but especially those because are the most commonly used at the beginning of the treatment, increases the suicidal ideation and the potential of committing suicide, which is a complication of the depression. And you need to be aware about this, and you need to explain that to the client. They should communicate these changes in the ideation. Another topic important in this group of medication, they could elevate too much the serotonin. If the serotonin elevates too much in the brain, the person becomes severely ill. The person will have alteration of the mind, so become agitated like crazy, and then can evolve to lethargic and coma. The person can have seizures. The person can have fever, hyperthermia without having infection. The person will have an overactivation of the sympathetic nervous system with tachycardia and hypertension, sweating, etc. This is a fatal condition, a fatal condition that should be have in mind, and could be more frequent if the patient is taking herbal called St. John's wort, which is an anti-herbal, non-controlled, over the counter, that also could elevate serotonin. Okay, serotonin. Other medication like the triptan for migraine, like the certain analgesic like tramadol, certain antibiotic like linezolid or linezolid, okay, can also potentiate those serotonin syndrome. Understand that all those medication takes time to start working. So the improvement, the significant improvement of the mood usually is observed after 3-4 weeks of taking the medication. This medication should not be discontinued suddenly because now the client can have a rebound of the depression. One of the mental illness that we start, knowing is the bipolar, psychosis, specifically type 1 bipolar psychosis. And this bipolar have a period called mania, where the patient have a very exalted mind. Okay, those patients, after being controlled with antipsychotic medication, are placed in the medication lithium that prevents the recurrence of the bipolar episode. Lithium is very effective, and the most important from the point of view of lithium, from the point of view of nursing, is that lithium has a very narrow therapeutic range and can become toxic. Okay, levels above 1.5, usually the therapeutic level is between 1.2, but 1.5 or more are toxic levels and can produce serious consequences. Uh, we need to avoid lithium toxicity, and to avoid lithium toxicity, we need to know the three main causes of lithium toxicity. One, and very important, is when in the body the amount of sodium is lower than usual. It happens when people are following a low sodium diet or are taking diuretics. So it's not good to have a low sodium diet or having diuretics at the same time as the patient is taking lithium. You need to have that in mind. The other cause of lithium toxicity, because the lithium is excreted in the kidneys, is having renal disease. You know that renal disease occurs when the patient have elevation of the creatinine and the BUN. And of course, the urinary output decreases. Renal diseases are other parameters that we need to monitor in patients taking lithium. And the other is dehydration. When the person dehydrates, well, mainly when have gastroenteritis, vomits and diarrhea, or have polyuria, diabetic lines, etc., etc. For that reason, patients taking lithium should be educated in the encouragement of consuming abundant liquid, at least more than 2 liters of liquid per day. The long-term use of lithium can produce hypothyroidism, okay, because it blocks the thyroid function. When the lithium is toxic, one early manifestation is gross tremors in the hands and nausea and vomit. So before the patient is dead, before the patient has cardiac arrhythmia, before the patient has severe ataxia and seizures, you need to be monitoring for the early manifestation. Don't wait that the patient is dead, okay, to say, oh, you had lithium toxicity. Trying to detect at the beginning. Gross tremors, nausea, and vomits are, classical symptoms of early toxicity. For psychosis like the schizophrenia, we have antipsychotic medication. The antipsychotic medication can be classified in the old one, the typical, and the new one, the atypical. The old one, the typical, the prototype is the haloperidol. Haloperidol. Others could be the chlorpromazine and different phenothiazines. Those medications have many side effects. That's why have been gradually replaced by the new one, by the atypical. Those medications works mainly inhibiting the receptors of dopamine, a neurotransmitter that we have normally in the brain that when is deficient can produce Parkinson-like a condition called extrapyramidal syndromes. Yes. The new antipsychotics, the atypical, we have the oldest, which is the clozapine. Clozapine need to be known because clozapine, has been mentioned before, can depress the bone marrow, producing drop of white blood cells. I mean a granulocytopenia, because the white blood cells also are called granulocytes. No, granulocytopenia. The most abundant white blood cells are called granulocytes. Granulocytopenia and agranulocytosis is the same. Okay, it's produced by the clozapine. But we need to know the name of the other. For example, the quetiapine, the risperidone, the abilify, etc. We need to recognize those. How we do that? Making flashcards and repeating the names, reading the names several times until you are able to recognize those medications as members of the antipsychotic family. Of all the adverse effects that those medications can produce, the worst is called neuroleptic malignant syndrome. Why? Because the neuroleptic malignant syndrome can kill. Is very similar in symptoms with the serotonin syndrome and can be as lethal as or fatal as the serotonin syndrome. It's characterized by muscle rigidity. It's very typical. The patient becomes very rigid, very stiff. Hyperthermia, so again, fever, hypertension, and tachycardia. Again, altered mental status, seizures, and death. The client that is taking any antipsychotic and presents any of those symptoms, immediately the next dose of the antipsychotic should be withheld. Immediately the doctor should be informed and be sure that this patient is going to be admitted in ICU because the severity of the syndrome. The other more common, less dramatic, less severe, but common, phenomena can be seen with the antipsychotic, especially the old one, especially the typical, are the extrapyramidal syndrome. This syndrome occurs because the drop in the action of the dopamine. We can have Parkinsonism, that is a condition similar to the Parkinson, in which the patient becomes rigid and with a shaking and move very slowly. The acute dystonia, where the client develops sustained abnormal movement of the eyeballs, like this is called oculogyrochlisis, or can have open mouth and cannot close the mouth, or can have a torticollis. Yeah, the akathisia, in which the patient doesn't stop moving, is a restlessness, is continue jerking and moving. The target dyskinesia that start in the lips with lip smack and protrusion of the tongue, and those are Parkinsonism. This kind of side effect, except the tardive dyskinesia, can be reverted, okay, lowering the dose of the medication and using the anticholinergic drugs benztropine. The tardive dyskinesia requires the discontinuation of the medication because it's not reversible, cannot be reverted with benztropine. Don't forget the problem with the clozapine and the granulocytopenia, and know that those medications have less severe, okay, side effects like photosensitivity. The patient, if is exposed to sunlight, can have a severe burn. Orthostatic hypotension. Remember that this is a cause of falls and fractures, so you need to ask the patient to change position very slowly. The galactorrhea and irregular menses or menstruations is found with the use of haloperidol, and the new antipsychotic, the atypical antipsychotics, can produce weight gain and glucose intolerance, something called metabolic syndrome. Of the medication that can stimulate the central nervous system, of course, the best known is caffeine. But then we have the amphetamines, specifically the methylphenidate, which is commonly used for people that have problem of attention deficit, people that have bad school performance, problem of learning, etc., because cannot concentrate in what they want in learning, in acquiring knowledge, and because it's an epidemic. Okay, many children are taking that, also adults, and for that reason it's frequently tested. You know that being those medication stimulants, they can produce insomnia. So it has a practical approach. Most of the dose should be given early, preferably in the morning, and the latest that should be given at least 4 to 6 hours before going to sleep, because otherwise you are going to have insomnia. And of course, if you are taking this stimulant, don't take also too much coffee, cola, chocolate, tea that also contain caffeine, which is a stimulant. Those medications, decrease the appetite, so the person is going to eat less. That's why some people use this kind of medication to lose weight. The problem is that when you have a child with attention deficit and learning disabilities, and the child is taking this medication, that the child doesn't want to eat, and children need to eat. They're growing. They need to have a complete diet. So the way of bypassing that is offering nutritious snack. Okay, the stuff that they like finger food, and you need to find that the content of calories of this snack should be high, the content of protein should be high, the content of carbohydrates should be high, good fats high, vitamins high. So in a small amount, the little food that they are eating, they are obtaining the calories and the nutrients that they need. The other problem of this stimulant, they can stimulate the sympathetic nervous system, producing tachycardia, producing hypertension, and dysrhythmia, so alteration of the rhythm. That's why people can develop dysrhythmia, like the atrial fibrillation that we studied, or the supraventricular tachycardia, and some people with bad luck can even suffer sudden death. Angina is seen mainly in people, older people taking this medication that could have already affected the coronary arteries. People with ¿cómo se llama? Mental problems. Some people are, having predisposition, genetic predisposition to have psychosis or mental problems, mental diseases. People with this predisposition taking amphetamine, like the people that take amphetamine for pleasure, for addiction, no, for abuse, can develop, psychotic symptoms, hallucination, paranoia, etc. And when people are used to take, frequently these kind of stimulants, when they stop the stimulant, even the caffeine, they can have depression, tiredness, somnolence, hunger cravings, and even psychotic alterations. Anticonvulsants or antiepileptic is a family of medication that we need to know very well, because there are many individuals taking those medications because they suffer seizures, and they can have a perfectly normal life when they prevent or inhibit the seizures, taking those medications every day around the clock with discipline. The anticonvulsants generally have a narrow therapeutic range, and for that reason it's very important to measure the blood level, the peak and trough. So it's important that they don't go below the therapeutic range, because now the patient will have a seizure. But if they go above the therapeutic range, they can have toxicity, and the toxicity generally is not good. But nevertheless, many of them can have side effects that cannot be avoided, like in the case of phenytoin. Phenytoin is one of the most commonly used anticonvulsants or prophylactic for the seizures, and in toxic levels, they can produce even death. They can produce ataxia, can produce nystagmus, an abnormal movement of the eyeball that make the patient very dizzy. Ataxia is lack of coordination of the movement. Even the person can have a depressed level of consciousness and coma, and they can have cardiac arrhythmias, AV blocks, and severe bradycardias. But the most important to remember is that something that cannot be avoided, something cannot be bypassed in patients taking phenytoin, is that they can develop enlargements of the gums. Maybe not so much like this, but it's something similar. This is called gingival hyperplasia. It's expected. It cannot be bypassed. And the most important is to teach the client to take a special care of these enlarged gums, having a very good buccal hygiene, brushing the teeth frequently, but with soft, bristled toothbrush. A careful use of the flossing, because flossing can, make the person bleed. So you need to be very careful with the flossing, and of course, going frequently to the dentist. The carbamazepine has as an expected side effect sedation. So the patient at the beginning is going to be sedated, should not be driving, etc. And most of the dose should be given at night. But the carbamazepine have a very bad, unacceptable side effect, adverse effect, that is the bone marrow depression with granulocytopenia. So patients taking carbamazepine need to be regularly done the CBC or complete blood counts to check the level of white blood cells. Thanks God, this bone marrow depression is not common. It's just one in hundreds. But this one needs to be detected by the nurse that is giving the carbamazepine to this client, and the education should be given. How you experience a drop in white blood cells? Well, you will start having infections. The first part of the body that is going to become infected is the throat, because in the throat you have a lot of bacteria. Part of the normal flora is the first place that will become infected. So the earliest manifestation of a bone marrow depression and granulocytopenia is sore throat. You know what is a sore throat, and possibly fever. The valproic acid is frequently used in the treatment of seizures. It's also used like the carbamazepine together with the lithium as a mood stabilizer. The problem that could bring the valproic acid in some patients, not in all, is hepatotoxicity. So the patient can develop nausea, can develop jaundice, and can have elevation of the AST and ALT that should be monitored regularly in patients taking valproic acid. Gabapentin and pregabalin are two anti-seizure medications that are used more frequently for pain, chronic pain, and neuropathic pain than for the own seizure. Hundreds of people are taking gabapentin, which is the Neurontin, the brand name, and pregabalin, which is Lyrica, because they suffer of chronic pain. There are people who have rheumatic problems like the fibromyalgia, and people that suffer of neuropathy, damage of the nerves for several causes. The most common is the diabetes, long-standing diabetes. But also could be, for example, shingles that produce inflammation of the damage of the nerves. So this nerve or neuropathic pain responds well to this anti-seizure medication. Levetiracetam, okay, Keppra. Levetiracetam is a frequently used anti-seizure medication that is very efficient, very good, but especially in children and adolescents at the beginning of the use of this medication, the mind of some patient with predisposition will start having suicidal ideation and even can have psychotic ideas, delusions. So there is a black box, a warning in those boxes of the medication that warns parents and doctors and nurses about this possibility. There are many other anti-seizure medications, but all those are the most important. Don't forget that the IV benzodiazepines are used in status epilepticus as a PRN, but those medications are for be taken around the clock every day without suspension because the compliance is so important. If a person that suffers of epilepsy decides the weekend not taking the medication because he's going to drink alcohol or is going to be partying, then this person in the party can start having seizures, and the seizure don't stop and requires to call 911, and 911 need to administer IV diazepam. The patient needs to be hospitalized to receive IV phenytoin or maybe a general anesthesia, a drama, a catastrophe. So you need to explain that to the clients, the importance of the compliance, because the risk of having a status epilepticus if the client discontinues the medication suddenly. And don't forget that we mentioned before that anti-seizure medications are one of the hepatic inductors, the inductors of the seizures, inductors of potentiation, making bigger the seizure of these enzymes that we have in the liver. So now, for example, oral contraceptives that were efficient before to prevent pregnancy can become non-efficient, and for that reason it's better to use barrier contraceptive. Of the many respiratory medication that you should know, you need to know the difference between an antitussive, an expectorant, and a mucolytic. The antitussive are used when the cough is dry, is non-productive, and there is no reason to have the cough. Those coughs are very irritant and could be contraindicated in certain circumstances like brain edema, brain hemorrhage, aneurysm in the brain, surgery in the eye, surgery in the neck, etc., where coughing is not convenient, especially if the cough is without phlegm, without anything to be expelled. The most potent of the antitussive, the inhibitors of the neurons that you have that produce the reflex of the cough, is the codeine. Codeine is an opioid, the same family of the morphine, the fentanyl, the hydrocodone, of the Percocet, etc. But because these kind of medication depress the cough center, can be used as syrups to suppress the cough. The one that doesn't belong, and is not controlled, doesn't belong to the opioid, is the dextromethorphan, or DM, that can be found frequently when you buy a cough syrup in over the counter in any pharmacy. Um, it's important to understand that being an opioid can produce in excessive dose, okay, respiratory depression, has the potential of abuse, and that all the opioids produce a lot of constipation, an important detail. The spectrums are medication that do the same that happens when you drink a hot soup or something spicy, that you start coughing and expel flames. Is an expectorant. Is to increase the production of sputum and to clean the airway. And guaifenesin is the prototype of the spectrum. Nevertheless, I insist that the cheapest and the best of the spectrum is water. Mucolytic and a special group of medication, specifically the acetylcysteine, which break down the chemical links of the mucus, making the mucus from thick and tenacious and adherent in a liquid mucus that is easier to expel. This has as a bad effect is the smell. It smells like rotten eggs, so it can produce like a upset stomach when the patient. It is giving a nebulization. It's giving a nebulization. For patients suffering of bronchoconstriction, which is a narrowing of the bronchi seen in asthma and seen in patients with chronic obstructive pulmonary disease, or COPD, I mean emphysema or chronic bronchitis, the bronchodilators play an important role. Of all the bronchodilators, one of the most commonly used are the beta-2 agonists. Remember that the epinephrine that we produce in the body works in alpha and beta receptors. The beta receptors are beta-1 in the heart, increasing the heart rate, beta-2 in the bronchi, dilating the bronchi, which is what you need to have when you have a fight or flight reaction. The alpha receptors are in the arteries, producing vasoconstriction, and in the prostate gland, producing contraction of the muscle of the prostate, obstructing the urinary outflow. The beta-2 selective adrenergic agonist works mainly, not exclusively, but mainly in the beta-2 receptors of the bronchi, and are better than the epinephrine because they mess less, they produce less problems in the heart and in the alpha receptors. They have two classes, the short-acting and the long-acting. The short-acting, the only one that you need to know is albuterol. The albuterol is given inhaled, is given through the inhalation of the medication going directly to the beta-2 receptors in the bronchi. The albuterol, the inhaled albuterol, is considered the life-saving medication in acute bronchospasm, is the rescue inhaler, and is the only one that can be used in the acute bronchospasm, in the acute, for example, asthma attack. The long-acting are the salmeterol and formoterol, but because they act slowly and because they are not useful in the acute crisis, they are used all as a long-term control, so given around the clock with other medication. So this is the most important. How they work, they stimulate the beta-2 receptors in the bronchi, opening, relaxing the smooth muscle of the bronchi and opening the bronchi. They have a little action in the beta-1 of the heart, but yes, they have a little increment of the heart rate. The patient will experience some tachycardia, some palpitation. Patients that suffer of hypertension could have a little increment of the blood pressure because these are kind of medication that are like epinephrine, are sympathomimetic, are adrenergic, like their adrenaline, which is the same as epinephrine, tends to increase alertness and can make you nervous and produce some insomnia, because in the fight or flight reaction, you must have elevation of the sugar in the blood, the glycemia, the glucose, because you need to produce more energy in your muscles. You have a mild elevation of the glucose with this medication, and it's interesting, it can decrease the amount of potassium in the blood, which could be an useful intervention in patients that have abnormally high potassium in the blood. So in the future, you could see that sometimes they use albuterol to decrease high potassium in the blood. But it is, apart. Remember that the long-acting beta-2 agonists, or LABA, are not used in the acute asthma. Or other type of bronchodilators is the anticholinergic ipratropium that works blocking the acetylcholine receptors in the bronchi and could be used together with the albuterol. So the ipratropium can be used together with albuterol because working in other parts of the system potentiate the action of the albuterols. The other component of the diseases of the bronchi, like asthma and COPD, is the inflammation of the mucosa that produce the inflammation release mediators or substances that make the muscle contract, so produce bronchospasm, and also make the mucosa thicker and produce a lot of mucus. All this participates in the bronchospasm. So in the treatment of those diseases, doctors prescribed medication for inflammation. We have several medications for inflammation. For example, we have the inhibitors of the leukotrienes, like the montelukast, singular. We have the inhibitors of the degranulation of the mast cells releasing histamine and other inflammatory mediators like the chromoglycate, but the most potent and the most commonly used are the glucocorticoids, the inhaled glucocorticoids. Also, glucocorticoids could be used injected or in tablets, but then they produce systemic all over the body effects, which are not very good. So this is the advantage of having the glucocorticoid inhaled, because the potent anti-inflammatory action of the glucocorticoids are going to be exerted almost exclusively in the mucosa of the bronchi and not in the rest of the body. There are many inhaled glucocorticoids, budesonide, fluticasone, etc. But the prototype is going to be fluticasone. The action is immune suppressor, so suppress the inflammation. Inflammation is part of the mechanism of defense of the body. When the body is defending from bacteria, viruses, or any kind of foreign substance, or if there is cells that are dead in the body need to be eliminated, the defenses of the body work through a process of inflammation. So when we suppress inflammation, we are suppressing the defenses. And this is the way that it works, decreasing the inflammation, this overacting defenses mechanism in the mucosa. This medication cannot be used for the acute asthma attack. It's given around the clock every day to prevent the asthma attack, decreasing the inflammation. So our long-term treatment for asthma and COPD. These medications have too many important side or adverse effects. Side number one, they can induce the growth of a form of fungus, a yeast in the mouth and the throat called candidiasis. The name of when this grows there, the late term, is thrush. And to prevent this fungus growing in the mouth and the throat, we teach the client to rinse and gargle water, plain water, after each dose of the medication to remove the residues of the medication that are left deposited in the mucosa. And the other side effect is bronchospasm. You say, well, why they use that? Because they are potent anti-inflammatory. So how we bypass, how we solve the problem that when they are inhaled, they produce bronchospasm? Very simple. Before inhaling the glucocorticoid that produce bronchospasm, reactive bronchospasm, we inhale a bronchodilator, in this case albuterol, or in long-term treatment could be a LAVA, a long-acting beta blocker agent, no? And this way the bronchi are forced to be opened, and then after that is used the glucocorticoid. So always first the bronchodilator and second the glucocorticoid. Remember that the glucocorticoids have no indication for the acute asthma attack. Only the albuterol, maybe the ipratropium, and the oxygen are the medication for acute asthma attack. There is a third-line medication for asthma. It is the theophylline that is used because it's very toxic. Is used only as a last resort in patients that don't respond to the regular treatment. It's very toxic, belongs to the family of the caffeine, but is very potent, so can produce a lot of cardiac arrhythmias and tachycardia, produce alterations in the nervous system, the stimulation of the nervous system that can reach the level of the seizures, and can produce a lot of stomach discomfort. From the family of the diuretics, we need to know the subfamilies. I mean, the loop diuretic, thiazide diuretic, the potassium-sparing diuretics, and the osmotic diuretics are the most important. I know we have also the anhydride carbonic inhibitors, but these are used less frequent. We can learn that later. The loop diuretics, probably the most important to know. Why? Because are the most potent. And we need to know the names: furosemide, bumetanide, torsemide. What we know about this medication: when this medication is given, immediately the kidneys will react, throwing away in the toilet the sodium. Thing that normally doesn't occur because we have a potent orders in the kidneys made by a hormone that we have called aldosterone, that the sodium should return to the blood after filtering in the glomerulus. Now this sodium, or at least part of this sodium, is going to be blocked from returning back into the circulation. And because it's not returning back after filtrating in the glomerulus, structure that you should know from anatomy and physiology, subject that you passed with excellent grades previously, then when the sodium is in the tubule, it's not going to be reabsorbed back. If the sodium is not reabsorbed back, a molecule of water is going to follow each molecule of sodium. Also a molecule, an atom of chloride. So sodium, chloride, and water are expelled, are excreted, are eliminated through the urine when these kind of diuretics are administered. Okay, are administered, and they are very potent. Even they can produce hypotension. That's why they need to be administered when IV, very slowly, in more than 2 minutes. This medication can produce hypovolemia, because if too much diuretic is given, then the patient have hypovolemia, little water in the body. Can produce hyponatremia, can produce hypochloremia, chloride, but because they also force the excretion of potassium, they have the potential of producing hypokalemia. The potassium should be in blood in a very narrow range, 3.5 to 5 milliequivalents per liter, and any deviation downward or upward of this tiny range is potentially lethal through the cardiac arrest. So for that reason, it's very important to educate clients taking this kind of diuretic to replace the potassium through the diet and through potassium supplementation. So we need to become knowledgeable about the food that is rich in potassium. We need to read about that. Um, the other adverse effect that the loop diuretics specifically can produce is ototoxicity. So diuretics in high concentration in blood, that's why it also need to be administered very slowly when administered IV, can produce damage of the optic nerve, the vestibulocochlear nerve, the eighth cranial nerve, that is the one that we use to hear. And for that reason, the person can experience tinnitus, loss of hearing, and vertigo, which is an important detail to observe. The thiazide diuretics are less potent than the loop diuretics. For that reason, are not used in emergencies, are not used when the patient have incompetent kidneys, but are very useful in the long-term treatment of hypertension. The prototype of the thiazide, the hydrochlorothiazide, but also we need to know that chlorothalidone and indapamide are also thiazide family diuretics. The side effects are very similar as the side effects of the loop diuretics, but of course less intense. They also have two specific details to be known. They can increase the uric acid in the blood. For that reason, people that suffer of high uric acid or hyperuricemia, and those people frequently suffer of a form of arthritis called gout, should not take this kind of medication. They elevate the amount of calcium in the blood, which usually is useful because we usually have need of consuming a little more calcium, especially older people that have tendency to for the development of osteoporosis. So it is considered a beneficial effect, the tendency to increase the calcium in the body. And the last one is very important: cross-allergic reaction with sulfas. Sulfas are antibiotics, and a lot of people are allergic to sulfas. Probably there are more people allergic to sulfas than to penicillin. If a person is allergic to sulfas, probably will also be allergic to this kind of diuretics, and vice versa. If a person has been already known to be allergic to thiazide diuretic, if they develop allergic reaction when they consume once thiazide, then should not take sulfas because probably they will be allergic to sulfas. The other family, the potassium-sparing diuretic, the prototype is the spironolactone, spironolactone. There are two more, amiloride and trianterene, but at least spironolactone or spironolactone is the most commonly used. Those medications have the same action. They inhibit the absorption of sodium, chloride, and water and are diuretics. But the difference is that they, instead of promoting the elimination of potassium, they retain potassium. For that reason, cannot be used in people that have high potassium, like people with renal failure. Independently of this action, the spironolactone have an anti-testosterone action, producing impotence, gynecomastia in men, and menstrual irregularities in women. The osmotic diuretics, the prototype is the mannitol that are used in emergencies, specifically brain edema and acute glaucoma. Diuretics should not be given at night because it's going to interrupt the sleep. Going frequently to the bathroom should be given in the morning. The best way of knowing the diuretic is working is to weigh the client every day. And remember that for each kilo that the person is losing is 1 liter of liquid that has been eliminated. Potassium should be always monitored in either kind, because if it is a loop diuretic or a thiazide diuretic that lower potassium, you need to look for hypokalemia, less than 3.5. But for potassium-sparing diuretic like spironolactone, you need to look for hyperkalemia, more than 5 milliequivalent per liter. So you need to know when to recommend food rich in potassium and when to restrict food rich in potassium. Obviously, the restriction of food rich in potassium is when the patient is taking spironolactone. The lithium becomes more toxic when the sodium is low, and all the diuretics lower sodium. So that's why it's not good to take diuretics together with lithium. And as we know, dioxin becomes more toxic when the potassium is low. So when the patient is taking potassium wasting diuretic like the loop and the thiazide diuretic, you need to be very careful in monitoring the potassium and promoting the normalization of the potassium with potassium supplementation and food rich in potassium. As in any medication that has the potential of producing hypovolemia and lowering of the blood pressure, patients taking diuretics should be taught to change position slowly to prevent the orthostatic hypotension, the drop of the blood pressure that occurs when you are extending and can make you fall and have a fracture. Medications used for blood pressure and for the heart, the beta blockers. The beta blockers is the LOL group because the majority ends in this syllabi. Okay, propranolol, nadolol, carvedilol, acebutolol, etc. are examples. They can be classified in those that are non-cardioselective, the one that blocks beta 1 in the heart, but also beta 2 in the bronchi. They are not good. They are not good for people with asthma because if you block the beta 2, you produce bronchoconstriction. Yes? They are the opposite of the albuterol that stimulate the beta 2. So no good for asthma. Yes? In general, beta blockers are no good in asthma, but especially the non-selective because specifically they block the beta 2. So example of the non-selective propranolol and nadolol. The selective beta 1 blockers are better in general because they mainly block the beta 1 receptors in the heart. Metoprolol, atenolol, and acebutolol are the most important to memorize. They have a chronotropic negative and inotropic negative action. Chrono means in Greek time. So a chronometer, yes? Chronotropic is the capacity of any medication or changing the number of times that the heart contract in 1 minute. Well, how is called that? Heart rate, yes? So any medication that can change the heart rate up or down is called chronotropic. If the change is up, what means you change the heart rate up? Okay, what means that? That you accelerate the heart rate. So if you have 60 and now you have 100 because you are exercising, you have a chronotropic positive action. It's very simple. You don't need to dedicate half an hour thinking about this. A chronotropic negative is a medication that, slow down, okay, decrease the heart rate. And this is something that can be the action of the beta blocker. The beta blockers is a chronotropic negative medication. I know means strength, okay? So the heart is a muscle, and you can contract strong or weak. When you give a hand shake, you can squeeze the hand of the other person. It's a strong contraction, or you can make a very, soft, okay, disgusting handshake. Is to make you frontal lobule, okay, understand, no? And this is something that can be also be modified by medication. In the case, the beta blockers make the heart contraction weaker. Sometimes it is convenient when the heart is given a very strong handshake that breaks the hand of the other person. You can, reduce the strength of the contraction. It is beneficial because then the heart is going to rest a little and the blood pressure is not going to be so high. Yes. So the beta blocker have also an inotropic negative action. Okay, so it is interesting. So you need to get used of knowing many of the cardiovascular medication, which action has the medication in the chronotropism and which action has in the inotropism. For example, dioxin slows down the heart, so it's chronotropic negative, but by the contrary, make the contraction stronger, so it's inotropic positive. For example, calcium channel blockers, especially verapamil and diltiazem, they are like the beta blockers, chronotropic negative and inotropic negative. They, slow down the heart and make the heart weaker. Epinephrine, adrenaline. Adrenaline is chronotropic positive and inotropic positive. So make the heart beat faster, because when you are scared, when you are upset, or you are exercising and you are producing epinephrine, adrenaline, your heart beats fast and the contraction is strong. So it's not rocket science. It's very simple. It's very simple, easy to manipulate that. You don't need to make a mess of this, as far as you use these neurons that your mother and your father gave in your brain. Very good. So being a chronotropic negative, you need to be careful that not giving too much, because then can produce a more than adequate bradycardia. So for example, a person that have already a bradycardia, like a disease called AV block, a condition that requires a pacemaker because the heart rate is beating very slowly, of course, beta blockers should not be given. But the fact that they have an inotropic negative action makes a benefit in decreasing the blood pressure, and when the heart must rest, like a myocardial infarction, angina, etc., when you don't want the heart working too much, because then it's going to demand more oxygen that cannot be supplied because the coronary arteries are partially obstructed, then it's convenient to give beta blockers. Of course, the one that decides that is the prescriber, but you need to understand. You cannot be following orders like, I don't know, like a robot or like a monkey. We need to understand why the medications are prescribed. Very good. And the other important has been already mentioned, the non-cardioselective, the one that could block the beta-2 receptors, are contraindicated in asthma and COPD. Okay, so the other topic is that this kind of medication, like many medications, should not be discontinued suddenly, because the sudden discontinuation can produce a rebound, okay, hypertension, and rebound of hyperactivity of the heart, producing angina, because the increased demand of the oxygen that cannot be supplied but partially obstructed coronary arteries. For that reason, this medication should not be discontinued suddenly, but little by little. Another class of medication for blood pressure is the angiotensin converting enzymes, abbreviated ACE inhibitors. Drugs, chemical substances that inhibit an enzyme that we have in the lungs, or we have it, that activate the angiotensin 1, transforming the angiotensin 1 in angiotensin 2. Angiotensin 2, part of the renin-angiotensin-aldosterone system, is going to produce constriction of the arteries, which elevate the blood pressure, and secretion of aldosterone, which increase the sodium and water in the blood. If we inhibit, block this enzyme, then we have less angiotensin 2, less aldosterone, and the consequence of that is going to be vasodilation with drop of the blood pressure and less sodium and water in the circulation. This family is characterized by the end pril, captopril, enalapril, lisinopril, ramipril, etc. And the mechanism of action has been already explained. Which side effects are important? Of course, hypotension. And then you need to be very careful of not giving too much, because then too much hypotension can occur. But even with therapeutic doses, with normal doses, the first tablets, the first doses that we take can produce orthostatic hypotension, to which we are not used to. And if we change positions suddenly, then we can faint, we can pass out, and we can fall and have a fracture or a bad trauma. For that reason, you need to warn people to stay recumbent after the initial doses and to change position slowly. The most dramatic consequence of side effects, adverse effects of the ACE inhibitor could be angioedema. Few people do that, but you are responsible of knowing it and identifying and in making the adequate interventions in case of having one client developing angioedema. Generally develops soon, half an hour, 1 hour after the dose, and the person will complain of problem of swelling, but especially swelling in the throat, having hoarseness, stridor, the swelling of the lips and the tongue, etc. And you need to activate the rapid response team. Sadly, a common side effect, which is not life-threatening, is not catastrophic like angioedema, but so annoying and so persistent that requires the discontinuation of the medication, is the dry, relentless, hacking cough. If this happens, then it needs to be communicated to the doctor, because then the medication should be changed by the doctor, not by the clients. Should be changed. Hyperkalemia is a possibility in any medication that suppress aldosterone, because aldosterone says sodium and water for me, potassium for the toilet. If I suppress or decrease the action of this aldosterone, now it is going to be inverted. Yes, inversion. Now sodium and water to the toilet, potassium for me. So in patients with renal failure, patients that have already high potassium, these medications are contraindicated or used very carefully. There is something called substitute that you know is potassium that should not be used because it's too much potassium in patients taking this kind of medication. The same as in patients taking potassium supplementation or patients with renal failure. This group of medications are teratogenic, are contraindicated in pregnancy and lactation. The angiotensin II receptor blockers, or ARBs, are the same as the ACE inhibitors. The only difference is that instead of blocking the ACE enzyme, they directly at the end block the receptor of angiotensin II, both in the arteries and the adrenal glands, inhibiting the vasoconstrictive action of the angiotensin II and inhibiting the release of aldosterone. This group is called the sartan group because the termination is sartan, and they have the same characteristic as the ACE inhibitors, with the only difference that they don't produce this annoying cough that the ACE inhibitors can produce. Calcium channel blockers are nifedipine and lodipine, verapamil, diltiazem, and have a common termination except the family of the dihydropyridines that ends in pin, okay? But it's not useful. You need to know that are commonly used in cardiovascular problems are inotropic and chronotropic negative, the same as the beta blockers. So they produce, the drop of the blood pressure and put the heart at rest, and they decrease the heart rate. They are also vasodilators, direct vasodilators, because they inhibit the entrance of calcium inside the smooth circular muscle that are present in the arteries. But take care, also does the same in the smooth muscle that you have in the intestine, producing constipation. The same side effects as in any medication that lowers blood pressure, prevents orthostatic hypotension, can produce bradycardia in patients that have already bradycardia, and this is important. They have a strong potentiation by the grapefruit juice, so they become very toxic. So a lot of hypotension, a lot of bradycardia, a lot of constipation if they are taken with grapefruit juice. There is a family of medication for blood pressure that, apart of hypertension, are also used in all men with benign prostatic hypertrophy, are the alpha adrenergic receptor blockers. Remember, the alpha receptor of epinephrine are in the arteries producing vasoconstriction, and in the prostate gland, in the muscle of the prostate gland, producing contraction of the prostate gland, blocking the flow of the urine. If I block those receptors, then I dilate the arteries and I dilate the prostate gland. The dilation of the arteries lower the blood pressure, there's a vasodilation, and the dilation of the prostate gland will facilitate the urinary flow. Those medications, especially the first dose, produce a potent, severe orthostatic hypotension. For that reason, the first dose should be taken at night when the patient is already resting on bed. Dioxin is a cardiac glycoside. Those are synonyms that are inotropic positives and are used to make the heart stronger when the heart is too weak, like in heart failure. But it's also chronotropic negative, so could be used on purpose when the heart rate is too high or in certain tachycardias, like the atrial fibrillation or the atrial flutter. It's very toxic, has a narrow therapeutic range, and the low potassium in the blood potentiate this toxicity. So it's very important, the level of potassium in patients taking dioxin. You need to promote the potassium supplementation in the diet. The toxicity is very important. For that reason, when a nurse is giving a tablet of dioxin, need to be very sure that the patient is not already intoxicated by dioxin. When a nurse is giving a dose of dioxin, should count the apical pulse. Apical pulse is counted in the chest with an stethoscope. If this apical pulse is below 60 in adult, 90 in children, this is an evidence that is too much dioxin, and this dose should not be given. And the other reason for not giving the dose of dioxin is when the potassium is below normal, below 3.5. But there are other findings that also require withholding, stopping the dose of dioxin and calling the doctor. Is the presence of anorexia and nausea or vomit, and the presence of visual alteration like blurred vision or seeing halos of color around the objects and the person. Okay, so before giving any dose, evaluate, assess for this manifestation, and if they are present, don't give the dose and call the doctor that will order a blood level of the medication and a level of potassium. Nitrates are important drugs that are used in the management of the ischemic heart disease or coronary artery disease. I explained to you how it is happening and how many people suffer this condition. This condition produces chest pain called angina, and these medications are used to treat this angina. The prototype is the nitroglycerin, but it's an alternative that is isosorbate mononitrate. The mechanism of action is mainly vasodilation. It's a super potent vasodilators. That's why it's very risky to have this medication standing, because you can faint. Need to be taken while you're sitting or recumbent. Nurses preparing this medication should be wearing gloves, because the medication can be absorbed through the skin. If a nurse that has normal blood pressure, and some women have low blood pressure naturally, are absorbing this medication because are not careful when preparing the medication, can faint while passing medication. The vasodilation that they produce is expected to produce headache, as is something that you cannot avoid. The same as flushing, it is expected. The same as burning sensation under the tongue when the medication is placed there. All those actions are consequence of the potent vasodilation that they produce. Being so potent vasodilators, they decrease the workload of the heart, because the venous vasodilation produces decreased preload, and the arterial vasodilation decrease of the afterload. And this is the way that the heart rests and needs less oxygen, improving the ischemia and improving the angina. The nitroglycerin can be given PRN as needed in emergencies, in the moment that the patient is experiencing the chest pain, as a rapid form that could be in tablet or a spray. Sublingual because the sublingual route is rapidly absorbed because nitroglycerin is a fat-soluble medication and bypasses the first pass through the liver, goes directly to the heart. In the ICU, etc., can also be given IV. So it is used for the PRN administration for the treatment of chest pain of acute angina attacks. The main side effect is hypotension, so the blood pressure must be monitored. If before giving the medication, the nurse detects a blood pressure, a systolic blood pressure less than 90, must not give the medication, because you anticipate that it's going to drop even more, and then less than 90 systolic cannot guarantee the blood flow through the brain and through the heart, and can be worse the situation. The other condition that contraindicates the administration of this medication is taking erectile dysfunction medication. These medications, sildenafil, tadalafil, vardenafil, etc., combined with nitrate, produce such an intense hypotension that can be lethal. If a patient is having the chest pain, you teach the patient that they can use 3 tablets in total of the medication. But before starting the medication should be adopt the recumbent position to prevent fainting. And it's going to place the first tablet under the tongue. If 5 minutes after the first tablet the pain has not yet disappeared, should ask for rapid medical attention. So call 911 and continue placing the tablet every 5 minutes until a maximum of 3 tablets. The medication can be also be given around the clock, either in the form of tablets or patches, to prevent angina. In the case of the patches, is convenient to rotate the placement of the patch in a hairless area to prevent irritation of the skin, and also because patches make the patient accustomed, used to the medication, and then the medication stop working. It's good to put the patch on in the skin in the morning, but remove the patch before going to bed. Usually 12 hours on and 12 hours off. The tablets are given around the clock that don't have periods of holiday, of rest. This is the most important to know about. Of medication for cholesterol, we have several. We have the statin, we have the fibrates, we have the biliary salts in reabsorption inhibitor like cholestyramine and cholestyramine, etc. But the most important to know are the most commonly used. The statins that inhibit the enzyme hydroxymethylglutaryl coenzyme A reductase, the liver, that produce the endogenous cholesterol. So a part of the diet, the patient is taking this to decrease the bad cholesterol, the LDL cholesterol, and increase the good cholesterol, the LDL cholesterol. They are called statins because they tend to end in the termination statin. Those medications are given mainly at night because most of the activity of this enzyme occurs at night, and those medications have 2 important side effects. One is slow and can be detected just with blood tests, is the hepatotoxicity. That's why doctors will start checking periodically the AST and ALT, and if they see an important elevation, not a mild elevation, an important elevation 3 times the normal values, they discontinue the medication. It's important to avoid consumption of alcohol and other hepatotoxic medication like acetaminophen when you are taking statins. But the one that is catastrophic and occurs very acutely is the myopathy or rhabdomyolysis, which is a breaking down of the skeletal muscle with release of myoglobin to the blood and to the kidneys, producing a catastrophic reaction and renal failure. This manifests clinically with muscle pain and muscle weakness. So a person taking statins that complains of muscle pains, pain in the flesh, as they say, or weakness to climb stairs from standing from a chair, combing the hair, etc., immediately need to be evaluated for the possibility of this myopathy. If we wait until the rhabdomyolysis, the overt rhabdomyolysis presents and the patient start peeing brown because the myoglobinuria and develop acute renal failure, is of course too late. The test that they do to detect the myopathy is the creatine kinase. The creatine kinase, or CK to abbreviate, is a blood test that demonstrates the presence of this myopathy. The grapefruit juice can potentiate this toxicity, and that's why it's important to teach those patients to avoid the consumption of grapefruit juice.